Hi there. It's a Wednesday, and that means we turn our attention to matters medical. We're joined in studio, as usual, by our resident GP, Dr. Vicky Skitter. Hello, Doctor.
Hello, how are you
Nice.
doing?
I'm wonderful. Nice to see you again.
Nice to see you
Now,
too.
why do you bring up words like this with a person like me? Because you know I'm going to get it wrong. You know.
You just talk slowly.
Okay. Anesthesia.
Anesthesia. Yeah, that's good.
Whenever I say that, I feel like I've been drinking too much. You know what I mean? Or somebody has just put. I'm lying on a bed, and there are lights above me, and everyone's got masks. Well, everyone's got masks on everywhere now, but they're all in very funny clothes, and somebody has just zapped something into me, and you try and say anesthesia.
No, that's not going to work.
Now, tell me about the guest that you are zooming in for us today.
Okay, so I got hold of my friendly, very clever colleague, Dr. Ernie Welsh. He's a specialist anaesthetist in private practice. He's a honorary consultant to the WITS Anesthesia teaching unit circuit, and then he's also author or an editor of two thick books.
Thick books.
He's very clever. With the title Applied Pharmacology in Anesthesiology and Critical Care. Sure, that's a mouthful.
I read that a few years back. It was
sure.
The plot is absolutely magnificent. I won't tell you the ending because it'll. I don't want to let you down, but it's a great read. If you've got nothing to do on a Sunday afternoon, then that's the one to read. Dr. Welsh, thank you very much for joining us and taking the abuse before we even say hello to you.
That's all right. I'm glad Vicky called it an anaesthetist instead of anesthesiologist, because else we would have been here all afternoon.
No, I couldn't get that
right. Okay, I think you guys, everyone sort of gets a bit scared of when somebody comes along to you and says, okay, I'm Dr. Welsh, I'm going to be your anaesthetist for this particular procedure. I think people get scared because they don't quite know about it. They don't know, for example, why do you say you shouldn't eat anything for 6 hours before or have clear liquids for 2 hours before a procedure? I mean, what are the reasons behind that? We get told it, but we don't know the reasons behind it.
Yeah, I mean, we're quite sadistic, I think. It's a little bit of pleasure we get out of starving people. No, but there's good medical evidence of it. In the sort of early 1940s, patients used to get fed, for example, before a cesarean section because it made them strong to labor. And we discovered that patients actually suffocated on their own food. So they used to be given a meal of steak and potatoes, and patients would actually suffocate on the steak and potatoes that was in their stomach. The problem is that as you get anesthetized, you go off to sleep. Your esophagus and the little sphincters that prevent food coming back up into your mouth also get anesthetized. And as a result, if you've got any food or any fluid in your stomach, it will come up and actually run back down and into your lungs. The reason for the food is food takes a long time to empty out of your stomach. Clear fluids get emptied out a lot quicker. So within about 2 hours after clear fluid, you'll have an empty stomach. And all that's left is a sort of 150 mils of acid you produce in the stomach every hour. That fluid mixed with acid can give you a chemical burn on the inside of your lungs if you've had something to drink fairly recently before you have your anesthetic. So we got the combination of a chemical burn and basically suffocating from food that you've got in your stomach. That's why we starve you.
Okay, shame.
What do you mean shame?
How can you go without food for 6 hours?
No, I couldn't.
Well, we can do different things for emergencies. So we have slightly different techniques, but they're much more risky if you have eaten and you have got food in your stomach. But they are not ideal. They do then raise that risk of what we call aspirating, or which is basically getting your own food back into your lungs.
Doctor, you better take it over
Okay.
from here, because that's about the extent of my knowledge of anaesthetists.
Ernie, I see you at home and not in theatre. Are you a bit quieter? I would actually wanted to ask you what the current situation is around elective surgery at the moment due to COVID, and what you guys are doing and what you're not doing and why.
Yeah, it's a very interesting conundrum that when you're in the medical profession, you expect everybody working flat out with COVID. As anaesthetists, we ICU trained, so we actually are able to work in ICU and do COVID ICU work. But there's only a limited number of beds, particularly in the private sector, and nursing staff to actually man those beds. So one of the things that the hospital groups have done with each one of the waves is that they've stopped elective surgery because of the fact that we've got to put patients in beds. We've got to have nurses to staff those beds. And then there's always the risk with having an anesthetic that you might end up in intensive care or ICU, which means that you'd be taking beds away from COVID patients if we're doing elective things. It's a huge issue because in certain cases, like patients who need cancer surgery and urgent surgery that needs to be done, you've got to then delay this and add the risk of cancer doubling in size over the space of 6 or 12 weeks, against the fact that you actually don't have a bed to do it in. So electively, we've been very quiet. We've done quite a bit of emergency surgery. We've done emergency surgery on patients who've got COVID, which adds to a little bit of the fun around it. But in general, because of the fact that we don't have beds in the hospitals and staff to put patients into, we haven't been bringing people in for things like wisdom teeth, circumcisions, vasectomies, and cosmetic surgery or elective things that need to be done. If you've got an emergency, it will be done, but that is a bed you're going to be taking up. There are also some risks, and we don't really know them all fully because we're only about 18 months into this pandemic, of having surgery with COVID. There are certain risks, so we're trying to avoid that as well.
Yeah, I understand exactly where you're coming from, because just about 2 weeks ago now, we have a well, not we, as in not Vicky and I,
The
but
royal we, yeah.
yeah, our family has a mid-90s mother who slipped, fell, and broke her hip, and it was quite a mission to get her into a hospital. She's down in the Eastern Cape as well, which doesn't help much, where they would be able to do elective surgery because they considered it an emergency because of her age. But having said that, they got her into the hospital, and within 4 days she was out of the hospital into a step-down facility, just to make sure that the beds were being rotated as quickly as possible. So it must be,
Yeah,
I
absolutely.
can understand the dilemma there. Yeah. Doctor?
Okay, so I've got questions that patients often ask me as the GP, which I can't always answer. When patients are on chronic medications like blood pressure medications, antidepressants, diabetic medications, and even blood thinners, they often say, what must I do with my medication on the day of the surgery? What do you normally tell them?
So it's quite a difficult one because when you think there are a couple of thousand medications patients could be on, in general, most of them are okay with an anesthetic. And the best thing is actually to ask your anaesthetist or the surgeon. And surgeons often have a good understanding of what we would do because most of us have worked together for a number of years and have been exposed to a lot of cases. And they'll tell you which ones you can take, which ones you can't take. In general, things like diabetic medication, because you're starved, you don't really want to take that because you don't want to lower your blood glucose when you can't actually be taking any carbohydrate in. Things like blood pressure medication, generally, most of them are manageable if you've taken them before an anesthetic. It's usually easier if you're having an anesthetic in the morning and your medication is due to be taken in the evening. So take them in the evening as normal. The morning dose, by then it's actually worked through, and if it's going to drop your blood pressure or things like that, it will have done its effect. One thing that's also critically important is whatever chronic medication you're on, bring it into the hospital with you, because even like Jeremy said, we're trying to get patients in and out, and we get patients in and out often in 2 or 3 hours after cases, especially now with COVID pushing us to get beds cleared. But you may have to stay overnight, so bring your chronic medication in with you. Firstly, when I see you at the bedside, it actually makes it much easier to see exactly what you're on. And secondly, you've got it if you need to take it that evening, if you have to stay overnight when you weren't planning to.
What about smoking and drinking habits and those sort of things? Because look, I'm sure you and insurance brokers are in the same boat, where nobody tells you the truth about their smoking and drinking habits. Do you drink? Yes. How many beers a week do you have? Well, doc, maybe 4 or 5. Cuck. That oak is talking rubbish to you. What are the possible problems if you don't disclose the exact extent of your smoking or your drinking, or the fact that you may smoke cannabis, which is now legal, the fact that you may take other recreational drugs, if these aren't brought to your attention before you're going into a procedure?
Yeah, it's quite an interesting thing. Anesthetics is basically a pharmacological soup that we throw at you. So in an average anesthetic, you'll get somewhere between 7 and 12 different drugs. And if you think every single drug, all we're doing is we are using the beneficial side effects of that drug, and we're weighing them against the negative side effects. And we're hoping that the beneficial side effects will outweigh the negative side effects. And the moment you start adding 2 drugs together, your chance of getting drug interactions go up. So things like smoking, drinking, cannabis, cocaine, all those sort of things have effects of their own. And you add them now to drugs that we give you during an anesthetic, your chance of getting a complication or getting a drug reaction goes up. It's also nice to know how to handle them. So if you've got a smoker, for example, we might elect to put a breathing tube in slightly differently, or use a different type of breathing tube into your lungs so we don't irritate your lungs as much. We might even elect to give you a procedure where we don't need to put a breathing tube in, and we do it under a local anesthetic, a block or sedation or something like that. So those things are worth knowing. There's also the issue of things like cannabis use, where if you've taken cannabis in the morning of the procedure, you may need less analgesia or painkillers during the actual anesthetic. But because you're a chronic cannabis user, you may need more analgesia after the operation. So we like to balance those sort of things together, because generally we have a fairly good understanding of pharmacology. And then when we get a compounding factor, we've got to add it into that pharmacological mix that we've got between each other. And unlike the insurance brokers, we're probably not going to load you if you smoked sort of before you come into theatre.
And what about herbal supplements or herbal things that all patients take? Yeah. Are there certain things that come to mind that you would tell them, please do not take those?
Yeah, I mean, the issues with it are not necessarily just around the anesthetic, but around the surgery as well. So generally, anything that begins with a G is bad for bleeding. So ginkgo, ginseng, garlic, that. Arnica, people often take to decrease the bleeding and the bruising. There's no evidence that it actually works in the small studies that have been done, but it is a drug that can increase the actual bleeding during the procedure. And then things like St. John's wort, echinacea, a whole lot of them have different roles. Some of them can make your heart go a little bit faster, which can be a problem if we start adding other agents into it. And then we do things like we actually control your breathing during anesthetic. So your carbon dioxide levels, we try and keep quite normal. But raising your carbon dioxide levels because you're not breathing quite as well can interact, for example, with some of the weight loss medications, the fen-phens and those sort of things that as well. So yes, so generally try and avoid most of the supplements, vitamins, if you don't need to and absolutely need to take them. And if you're concerned, again, ask an anesthetist, ask a surgeon. And that's one of the advantages of being private practice. Your surgeon will be able to tell you who your anesthetist is, and get hold of them. Drop them an email, send them a WhatsApp, get hold of them, and ask them, should I be taking this or shouldn't I?
So basically what you're saying is you are not guys that we should be scared of, and just tell us the truth right up front and we'll be able to sort you out.
Well, I'm not going to say we're going to sort us out. I'm not that good. I still swim. I don't walk on water. But what I am saying is that give us a chance. If we've got the information, we've actually got a far better chance of being able to deal with it and make a plan, because it looks often like we're trying to get the same anesthetic out and each person's getting the same type of anesthetic. But for every single case, we weigh up the medication you're on, your medical conditions, what age you are, what procedure you're having, and we build it into a picture to try and come up with an anesthetic recipe or plan that we use.
Dr. Walsh, thank you very much for taking time out to join us on Mansfield today. It's been a fascinating conversation with you. Thank you.
Thank you,
Pleasure.
Ernie.
Thank you very much.
Cheers. Bye-bye. And to you, thank you, Dr. Vicky.
It's a pleasure.
It
See,
was-
yes, very slim.
Yeah, you see. Now,
He's together guy, this one.
yeah, no, he is. Yeah, if only all GPs were the same.
Like me.
Thank you, Doc. We'll see you next week again.
Yes.
Bye-bye.
Pleasure.
Dr. Vicky Skitter, our resident GP here on Mansfield today. If you did enjoy the show, don't forget to subscribe, and we'll catch you next Wednesday with more medical matters right here. Until then, bye-bye.